I'm Dr. Stephanie Valente. I will be discussing benign breast disease. So, first of all, patients are going to come in with a breast complaint. So, usually they're presenting to the office or the emergency room complaining of breast pain, a breast mass that they feel, an axillary mass, nipple changes such as inversion or nipple discharge, or any associated skin changes, redness, thickening, things like that. When you go to evaluate the patient, the first thing you want to do is go over their history of their complaint. So, especially for a breast mass, where is it located? How long has it been there? Are there any associated skin changes, texture, thickening skin, color, redness, different colors? Any nipple changes or discharge? Any axillary masses, and any breast pain that's associated with it. If there is some breast pain, you want to delve into that a little bit more and say, is it always there? Is it constant changing? Is it associated with the mass or the complaint that they present with? In the back of your mind, you always want to go over the risk factors that a patient can have for breast cancer and ask them about that. So we know that breast cancer is more prevalent with advanced age. The average risk for breast cancer is between 62 and 68, although there are obviously different degrees of when people can get breast cancer, young and old. Any person with a first degree relative with breast cancer or ovarian cancer, you want to get that information because that's extremely important. And not only who has breast cancer in the family, but how old were they when they got breast cancer or ovarian cancer. Patients with early menopause or late menarche, people without children, nulliparous, or a first pregnancy after the age of 30, have an increased risk of getting breast cancer. Although breast cancer doesn't play favorites and it can happen in anybody. We do know that dense breast tissue increases the risk of breast cancer. And additionally, breast cancer makes it difficult to identify a cancer on a mammogram. You want to discuss any use of estrogen replacement therapy, and especially in patients any prior radiation to the breast area. So Hodgkin's lymphoma was traditionally treated with mantle radiation, which was kind of from the neck and upper breast, any Ashkenazi Jewish ancestry. Next, you want to perform a breast exam. So there's two parts to the breast exam. One is the visual inspection, symmetry of the breasts and nipples. Are the nipples inverted or everted? If they're inverted, some patients are born that way, so you want to make sure that you ask, is this a new change in the nipple or is this something old? Is there any discharge of the nipple or scaling of the nipple? Additionally, on visual inspection, you want to look for skin puckering, any erythema, thickening, or what we call peau d'orange, which is French with kind of some swelling with thickening of the skin, kind of looks like an orange peel appearance. Next, you're going to move on to physical exam. So you're going to palpate the breast in all quadrants. And you want to, if there is a lump, you want to locate the lump. You kind of want to estimate the palpable size, whether or not it's mobile from the overlying skin or underlying chest wall. Is it kind of stuck to the surrounding breast tissue, or is it able to be mobilized? For lymph nodes, breast cancer usually spreads to the axillary lymph nodes first. So you want to check the lymph nodes in the axilla, move up to the supraclavicular and cervical lymph nodal basins, and you want to palpate the nodes. And if you do appreciate the nodes, are they enlarged? Are they mobile, matted? Or does the patient have any signs of upper extremity lymphedema? Let's go over some breast screening recommendations. So it's safe to say that annual mammogram beginning at age 40 is usually the best recommendation. That goes along with an annual clinical breast exam, usually by a physician, and then monthly self-breast exams, so breast self-awareness by the patient. High-risk screening recommendations are annual screening for high risk, usually would start 10 years younger than the first relative with breast cancer. So as I had mentioned, some risks for getting breast cancer might be somebody with breast cancer and asking that age. So if somebody has an aunt with breast cancer at age 45, their screening would begin at 35 instead of 40. High-risk screening consists of a clinical breast exam every 6 months, an annual mammogram, and consider adding an annual MRI. Now, the imaging, so the mammogram is once a year and the MRI is once a year, but they alternate every 6 months. So let's talk about imaging. For imaging, there are two types of mammograms that can be ordered. So a screening mammogram gives two views of each breast. So you get a cranial caudal view and a medial lateral view. So this is for a woman for her annual mammogram, no issues with her breast, doesn't have any complaints, just going for breast health screening mammogram. She would get a screening mammogram. Now, a diagnostic mammogram is a mammogram that would be ordered if somebody has an area of concern. So back to our chief complaint. If somebody has a lump, a skin change, pain in a specific area, or new nipple discharge, you're going to skip the screening mammogram and go straight to a diagnostic mammogram. And this could be an area of concern that's appreciated by the patient or the doctor. You can also get a diagnostic mammogram if you have a screening mammogram that identifies an area that's abnormal for which additional imaging to work that area up is needed. Now, an ultrasound usually goes with the diagnostic mammogram. So screening ultrasounds are not recommended, but if on a diagnostic mammogram or a patient has a lump, the radiologist is going to want to screen that with an ultrasound. So it's of a specific area of problem, and it helps with diagnosis of that abnormal area. Here's a two-view traditional screening mammogram. So again, as I mentioned, at the top is the cranial caudal view, which is marked on the films. Right side's on the left side of the screen, left side's on the right side of the screen. And then the bottom screen, which is the medial lateral oblique view. This patient has very dense breast tissue, so the breast tissue is white. How about MRI? Well, MRI is good. For breasts, we use it selectively. So in a patient that has breast cancer, specifically, it's good for determining what we call the extent of disease for an invasive lobular cancer. It might be used to help for patients who are undergoing neoadjuvant chemotherapy to really give a good measurement and response to disease. Anybody who has dense breasts, as that prior mammogram I showed, where it's really hard to detect a cancer. Anybody with a calculated high-risk screening, more than 20% on a Gale model or other high-risk model, and I'll go into that in a little bit later. And an MRI is best to check what we call implant integrity. So somebody who has implants where you're maybe looking for an implant leak or something, an MRI is the best test to use. Let's go over the radiology BI-RAD system. So every imaging report, whether it's a mammogram or an ultrasound or an MRI, must have a BI-RAD report. And what that is it's the final impression. So everything that the radiology says, and then under the impression, they give it a BI-RADS. So BI-RADS categories are between 0 and 6, and I have them listed here. So each BI-RADS category is kind of nomenclature for what the overall impression of the mammogram is, and it correlates to what specific follow-up is recommended. So on the left-hand side, it's BI-RADS categories for impression, and on the right-hand side, it's follow-up recommendation. So let's go through this. BI-RADS 0 means the assessment's complete. So a 0 doesn't mean negative. It means that the workup that's been done needs additional imaging. So if somebody has a screening mammogram that identifies an abnormality, the overall impression would be a 0 because diagnostic mammogram would be recommended. So 0, again, doesn't mean negative. It means additional workup is needed. 1 means mammogram looks completely normal, nothing to be worried about. Number 2 means that it's a benign finding. So they see something on the breast, maybe an old scar, something like that, but it's totally benign, but they make note of it, but it's benign. 3 is a mass or a finding on the mammogram that is noted appears to be benign, and usually that's followed with a short interval follow-up. Usually about, so if you see a 3, the next thing you say is, when does the radiologist recommend that this patient get follow-up? Because it's going to be sooner than a year. A 3 is usually 6 months, but it can be 3 months, and the radiologist should write that in their report on when they want them to be seen and what type of modality. So 6-month follow-up ultrasound or 6-month follow-up mammogram. 4 is a suspicious finding. A 4 means that a biopsy should be considered. So BI-RADS 4 means core needle biopsy should be performed. 5 means it looks like cancer. There's just no diagnosis. So a 4 means it might be cancer. 5 means it looks pretty much like it's going to be a cancer. And although 5 looks like it needs to be, that it probably is a cancer, 4 and 5s need biopsies to prove tissue under the microscope that it is a cancer. A 6 is a known cancer. So this is usually somebody who maybe, for example, had a mammogram and an ultrasound and had a core needle biopsy. There's a clip in the mass. We know that it's cancer, and then that patient gets an MRI. We know that there's cancer there, so the MRI finding would be a 6. Saying that that there's a known cancer in there and that they're looking for other things. So I talked about core needle biopsy. What is a core needle biopsy? Well, a core needle biopsy actually is standard of care. So it's the first intervention for an abnormal mammogram, so BI-RADS 4 or 5, for which a biopsy has been recommended. Excisional biopsy is really not standard of care, and I'll go over that in a little bit, but a core needle biopsy gives a tissue diagnosis. It's minimally invasive. Nobody has to go to surgery for it. And it can differentiate between benign, DCIS, or an invasive cancer. Additionally, if we do get a diagnosis of an invasive cancer, the core needle biopsy will be able to tell, the pathologist will be able to tell us what type of cancer it is, and you get receptors for breast cancer on the core needle biopsy. The 3 receptors that we test for invasive cancer are the estrogen receptor, ER, the progesterone receptor, PR, or the HER2 receptor. So I mentioned excisional biopsy is kind of old school, and so this is the difference. So whenever possible, a core needle biopsy should be performed to get the diagnosis. And why is that? Because a core needle biopsy is minimally invasive, and if it is a cancer, the cancer operation is very different than an excisional biopsy for a benign finding that might need to be coming out, like a high-risk lesion, which I'll go over later. So again, think a cancer operation is a lumpectomy, you're taking margins, lymph nodes, whereas an excision for like a papilloma is where you're just taking out that area. So you only want to put that patient through surgery once. So as much information as you can get about the cancer prior going to surgery is helpful. However, there are some indications where excisional biopsy is recommended. So if on imaging and core, so if you have an imaging and a core biopsy is performed and it shows benign tissue or something, the radiologist will look at the results of the mammogram and the pathology. And if they don't seem to match, the radiologist will call it discordant. A discordant biopsy is where excisional biopsy is recommended. So that's where additional tissue of that area needs to be removed so that pathology can look at it and make sure that nothing's being missed. Another instance is where a core needle biopsy physically or technically is not possible. So a lot of times this is an asymmetry where a stereotactic biopsy can't be done, or the mass is too close to the chest wall, or too close to an implant where if they do the biopsy, it might pop the implant. So in those cases, which are very rare, and a discussion with the radiologist on why an excisional biopsy is recommended. But in those cases, those patients would be taken to surgery. But again, those are far and few and in between. The standard of care is to perform a core biopsy before surgery. So let's go over the different types of core biopsies. So the first is a stereotactic biopsy. So here's a picture of a lady getting a stereotactic biopsy performed. They lay on what's called a stereotactic biopsy table, and a mammogram is performed with the breast hanging below a hole. The radiologist uses the coordinates of the mammogram to get the best angle possible, and they perform a biopsy that way. So a stereotactic biopsy is recommended is if the asymmetry or calcifications can only be seen on a mammogram. So if you perform an ultrasound and nothing can be seen, then you can't biopsy that way. So a stereo biopsy, again, is for asymmetry or calcifications. An ultrasound guided biopsy is where there's something identified on a mammogram where it's also identified on an ultrasound. An ultrasound biopsy is a lot easier for the patient to do and the radiologist to do. So the patient lays on their back with their arm up over their side, and the radiologist uses an ultrasound to perform a core needle biopsy. Now, for both core needle biopsies, when they're performed, the standard would be to leave a clip in place after the biopsy so that the radiologist or the breast surgeon can prove that the area that was of question has been appropriately biopsied. So after the biopsy, the patient would get a mammogram to prove that the clip's in the right spot. This is good practice guidelines. This is compared to a fine needle aspiration, where this is if the physician feels a lump in the breast, but it's not identified on mammogram or ultrasound. So if the physician feels a mass, but it's not identified on mammogram or ultrasound, it doesn't mean it's not there. It just means it's not able to be detected. So in that case, a fine needle aspiration is going to be performed. And how this is done is you can see the physician here has kind of that mass locked in between their two fingers to hold it stable. And then you use a 16 gauge or an 18 gauge needle and you perform an aspiration. So you aspirate some cells out through that needle. And that doesn't give a piece of tissue like a core biopsy does, but it gives a cytology diagnosis. So it would say atypical cells or malignant cells, but it doesn't, a fine needle aspiration cannot give receptors or type or anything like that because it's just pulling out cells, but it is helpful. So if you have a mass that's appreciated on exam as a palpable mass, but you don't have any imaging to identify a mass, you can't just let it go. You need to perform a fine needle aspiration, and they like to ask that on the boards. So what about a skin punch biopsy? So this is, as we go back to our chief complaint, somebody with abnormal skin findings. So they've got an abnormal rash that looks weird, raised lesions. This is essentially an office procedure. So it's an incisional biopsy. So you have this little core needle, a skin punch biopsy. So you numb up the skin, and this can be performed in the clinic, in the ER, on the floor. You numb up the breast skin with some lidocaine, and then this is like a little cookie cutter. And it's about a 2 or 3 millimeter diameter, and you just twist it and it takes out a piece of skin. That's the epidermis and dermis layer. And then that skin sample is removed, a stitch is placed in the skin, and that's sent to pathology. A lot of times this is the way to diagnose a concern for inflammatory breast cancer. This is an easy, simple way to perform an incisional skin punch biopsy to rule in or out inflammatory breast cancer. You can also do this for Paget's disease or any other abnormality in the skin to give a diagnosis. So let's talk about some benign breasts as the title, as we talked about. Let's get back to that. So some benign breast things that are totally benign, don't increase your risk of breast cancer. Breast pain, most of the time is not associated with cancer. Fibrocystic breast disease, so that's a lot of different cysts that kind of come and go, usually in relation to the menstrual cycle. Breast cysts, we're going to get into abscesses, talk a little bit about gynecomastia, and then nipple discharge. So again, back to our chief complaint. Let's go over breast pain. So breast pain, some facts is that it is common. About a third of patients complain of some type of breast pain, there are a lot of different causes, and it's good to reassure patients because they're scared that it's rarely a symptom of cancer. Not everybody's by the book, but really breast cancer and pain don't go along. However, when you're evaluating any new breast pain, you want to include a history, exam, and imaging to figure out what's causing that breast pain. Next, you want to characterize breast pain. So breast pain can be characterized into cyclic, non-cyclic, or extramammary. Let's go over these causes. First of all, let's go over cyclic. So if somebody says, I have got breast pain, it seems to be worse, at the beginning of the month or different times. It can be hormonally related, so related to the menstrual period. Sometimes people have breast pain when they're going through menopause. As the hormones change, or it could be fibrocystic breast disease. So non-cyclic, this is constant breast pain. Your differential diagnosis is going to be a mastitis, any type of trauma. So sometimes car accident, seatbelt trauma like that. Cysts, so a cyst can be a constant pain in a certain area. Thrombophlebitis, pregnancy, abscess, certain medications, a benign breast mass, or it could be a malignancy. Extramammary means outside of the breast. What could be the cause? Any musculoskeletal, such as costochondritis, scapular bursitis can cause referred breast pain. Fibromyalgia, especially with tender points or trigger points, and arthritis can cause it. And I've even seen herpes zoster where patients come in with breast pain, a few days later get that herpes pattern right across that dermal pattern across their breast. I did mention a cause of breast pain being thrombophlebitis. Key words are Mondor's disease. So this is a superficial vein thrombophlebitis. It's usually associated with trauma or strenuous exercise. Sometimes somebody's lifting heavy weights, went for a long run. And usually what this presents as is a palpable, painful cord. And it's usually located in the lower outer quadrant, kind of similar to what this picture is showing. And again, it's just a thrombophlebitis of one of the superficial veins in the breast. So the patient can be reassured, and it's treated with warm compresses and NSAIDs. It will get better with time. Breast pain workup and treatment. So first of all, somebody comes in with breast pain, specific area. You want to make sure their mammogram's updated. If they're able to point to an area of concern, you would put a little marker on that and send them for a diagnostic mammogram and an ultrasound of that area. So you, number one, want to rule out an underlying disease, underlying malignancy. If everything looks okay on the mammogram or the ultrasound, you could treat breast pain by going through, whether or not on exam it feels like it's part of the muscle, part of the breast, to differentiating whether or not the breast pain is actually coming from the muscle, the breast, or underneath. You want to review a patient's medications, make sure they're not taking anything that's new or different that could be causing breast pain. Caffeine is a big one. So, looking at how much caffeine they're taking, whether that's coffee, soda, chocolate, discontinuing that, changing to decaf coffee, see if that works. Sometimes that takes a good month or two to make any changes. Smoking, so smoking can cause breast pain. Make sure they're wearing a nice supportive bra. A lot of times patients' weight changes in size, but the bra measurement they got when they were 18 seems to stick with them for the rest of their life. So make sure that they're wearing an appropriate bra for their breast size. And then reassurance. A lot of people have breast pain. They've never had it before. They just want to make sure that nothing's going on underneath that's getting missed. So a lot of times it's just reassurance that everything appears to be okay. If they're having some breast pain, anti-inflammatories such as NSAIDs are helpful. Evening primrose oil, which is over the counter, is something that an ointment that they can rub on their breast that helps get topical relief. They can also use some topical Asper cream or lidocaine patches if they're having some pain as well. A breast cyst is a discrete fluid-filled sac of ductal epithelium, and it can present as a breast mass. It can present as breast pain. Not all cysts are painful. Um, so some can be painless, so they can notice a mass and then identify it in ultrasound, or they can come in as breast pain without a mass and identify a cyst as a cause. On ultrasound here, you can see that it's easy to kind of draw a line around. So on exam, you might feel a smooth, round, mobile area. Um, and an ultrasound, it's pretty classic. So black inside, nice, easy borders. Um, Usually a cyst doesn't get infected. So although it's painful, it doesn't mean it's infected. It's just kind of pushing on the surrounding breast tissue. Um, a long time ago, people used to take breast cysts out. We don't take breast cysts out anymore. So um, most cysts, again, people just want to know what they are. So they will resolve on their own. Really, very rarely do you need to aspirate them. So, but you can perform an FNA to aspirate the cysts. And I would say, really you only need to do it if it's a large cyst that's, giving some abnormal shape to the breast, or if it's causing a lot of pain. Um, if you do decide to aspirate the cyst, you want to make sure that the area should resolve on its own. It may or may not come back. But I like to do this under ultrasound guidance so that you can ensure that the entire cavity is collapsed and that the cyst is completely gone. And you don't need to send the fluid that we used to send all the time. Now you don't need to send the fluid unless it's bloody, and even then it can be bloody because you stuck the needle in. But if it's bloody, you should send it just to make sure that you're not missing something underneath. Let's talk about breast pain and erythema. So this is a case of a lady who presented with breast pain. So even though a cyst is the most common cause, you definitely also want to make sure there's no erythema. A mass could or could not be a cyst. It could also be an abscess. You want to check for any areas of drainage through the palpable area itself or through the nipple, and swelling. So in this girl, she's got a red swollen breast that looks different than her other breast. Usually breast pain and erythema is usually it happens in 20 to 50-year-olds. On evaluation, so obviously if somebody comes in with a painful swollen breast, the last thing they're going to want is a mammogram, but definitely an ultrasound is appropriate and necessary. So you want to rule out anything underlying. So looking at a large breast that's red, if the abscess is close to the skin, you're going to be able to identify it. But in these bigger breasted women, you could have a deep abscess that's going on and totally miss it because on exam, you're not going to be able to appreciate it, although the patient's going to be sore. So this first picture shows an ultrasound of a swollen breast, but there's really no abscess. The skin's thick, the tissue's kind of, angry, but there's no abscess to rule out. So this is an abscess, a mastitis, safe to treat with antibiotics. The middle picture is a red swollen breast with abscesses underneath. So you've got an abscess that's connecting to a deeper abscess. So kind of multiple deep abscesses in this patient compared to the picture on the right, which is an abscess that's right under the skin. So three different ways so an ultrasound is very helpful. So how do we treat a breast abscess and what is it? So this is that classic abscess right under the skin, skin's tense, looks like it's going to pop. A breast abscess is when the breast parenchyma becomes infected, which is mastitis, but then it starts to fill with pus. It presents as a painful red lump, most often caused by Staph aureus. It can occur in a breastfeeder, smokers, but the biggest cause is unknown, and somehow there's some break in the skin that the patients might not even realize, where it gives an opportunity for usually the skin flora, but it could be anything, to become infected in that area. So you always want to treat this with antibiotics. The first recommendation for a breast abscess is to treat with a needle aspiration and repeat that aspiration as necessary. Occasionally, for a deep abscess or multiple abscesses, you're going to have to do an incision and drainage. But if you can, you don't want to have these patients pack an open wound with, you know, a scar and all that stuff. So if you can perform something simple, you're going to want to do a needle aspiration for simple superficial cysts and incision and drainage for a large cyst, something that's multiloculated, thick, or not resolving with an aspiration. Let's go over this in a little bit detail. So here's a simple abscess intervention. Your simple abscess, you're going to drain. You're going to do a needle aspiration under ultrasound guidance if you can, using a 16 or 18 gauge needle. Once you aspirate that fluid, you're going to definitely send cultures and you're going to see that patient back. Usually you're going to see them about twice a week. Let them know sometimes it's going to take about 2 to 3 aspirations to get this clear, and that it usually takes about 2 weeks. The average is between 1 and 8 weeks, and the success rate for an aspiration is about 54 to 85%. Complex cysts are multiple, more than 5 centimeters, loculations, thick fluid that really can't be aspirated that well, deep or multiple. You're going to perform incision and drainage. You're going to have to pack. So anytime you do an incision or drainage of an abscess, you want to pack to leave a wick and allow that abscess cavity to drain. Alternatively, you can also put in a Penrose drain if it's deep. Another type of abscess is called periductal mastitis. So this is a chronic, recurring subareolar abscess with a draining fistula at the areolar edge or the vermilion border of the areola. It's usually associated with smoking, and this is what's known as Zuskas disease. So how does this happen? So the pathophysiology of the infection. Here's a picture of a milk duct. So what happens is that duct ectasia from smoking usually, but it can happen in anybody, usually leads to the squamous metaplasia. So our milk ducts are made up of cuboidal cells, but over time that duct ectasia causes squamous metaplasia to occur. Our squamous cells make and release keratin. Keratin plugs those ducts, causing blockage. So our normal ductal secretions that are microscopic stagnate within these dilated ducts and allow for overgrowth of bacteria. Eventually an abscess forms, and that abscess forms and it needs to get out, so it takes the path of least resistance and is going to drain at the areolar edge. The infection clears, but the blockage at the milk ducts continues, and so that process repeats, usually within months or weeks. So usually how this patient presents is a patient who presents with a history of multiple abscesses that occur in the same area. So they say, I've had this abscess, it drained on its own, I went and had it drained in the ER, I got him put on antibiotics, it healed up, a few months later it happened again. Got put on antibiotics, drained, happened, healed up, happened again. So how do you treat these women? So again, you're going to pay attention to their history. How many times has this happened? Is this happening in the same area? You know, are they a smoker? You're going to want to treat the abscess. So if the abscess needs drained, you're going to drain that. You're going to put them on appropriate antibiotics. And this is how you definitively treat periductal mastitis is once that patient's healed up from their acute infection, 4 to 6 weeks later, when the area is completely healed, you're going to want to take that patient to surgery and excise their diseased ducts and tissue completely. This is a paper from Dr. Lannon where he describes specific steps on how to treat recurring subareolar abscess. and fistula. So to go over this, what you're going to do is it's general anesthesia. The patient's going to have a lacrimal probe placed through the draining fistula up through the duct at the nipple. You're going to do a radial elliptical incision to incise the complete duct as well as the overlying tissue and any tissue around it that's firm and indurated. Next, you're going to remake the base of the nipple by putting a stitch at the base, remaking the nipple, and then sewing a radial incision. This procedure works really well. Next, let's switch gears to male gynecomastia. So usually what this presents with is a male who complains of a palpable lump beneath his nipple. So of course, on exam, you palpate the nipple and you feel it could be rubbery, it could be tender, but you definitely appreciate a mass. On exam, it's difficult to determine whether or not the mass is cancer, which although it's rare, it can happen in males. So you definitely want to get a mammogram and an ultrasound. On a mammogram, you get what's called flamed shape appearance. So this flame shaped tissue is pathognomonic for gynecomastia. Gynecomastia can be unilateral or bilateral. And if you're diagnosing gynecomastia, you don't need a biopsy to prove it. Again, it's something that our radiology colleagues can identify on imaging. And then you want to look for the causes. So why is gynecomastia happening? So it can be caused by alterations in testosterone and estrogen levels in the male. So obesity can cause it. Medications is a big cause. So look at the medications. What medication were they added recently? Spironolactone, cimetidine, omeprazole, any antipsychotics, history of marijuana or drug use. Or chronic disease such as hepatic or renal disease. So if the workup is benign, you can reassure these men that it's benign. Give them NSAIDs, look at the medication, see if it's safe to stop or change to a different medication. But rarely do you need to excise this. This is a great review paper by Dr. Braunstein on New England Journal of Medicine that goes over the workup of gynecomastia and the lab work that you would want to order. You're going to order HCG, LH, TSH, T3 and T4, estradiol levels, and then testosterone levels. So what do you do with all of those lab results as they come back? So this is a nice workup for what to do with these levels. So the big thing is for an increased HCG in a male with gynecomastia is to rule out actually a testicular germ cell tumor. So if a male has increased HCG, you're going to want to order a testicular ultrasound to identify a mass. Whereas if you're looking at increased LH, decreased testosterone, more of a primary hypogonadism, and looking at all of these other diagnoses as well. Let's switch gears to benign breast lesions. So I'm going to go over nipple discharge, papilloma, fibroadenoma, Phyllodes tumor, radial scar, ALH, LCIS, and ADH. Let's go over fibroadenoma first. So a fibroadenoma is a solid, benign, encapsulated breast tumor that arises from the epithelium and stromal of the terminal ductal lobular unit of the breast. Long story short, it's a benign tumor. It's common. It's the most common benign breast mass. It usually occurs in ages between 20 and 40 years old, and it usually presents as a painless, well-circumscribed mobile mass. About 10 to 20% of fibroadenomas when a patient presents are multiple or bilateral. So if a patient presents with a palpable mass, very important to do a bilateral thorough breast exam to make sure that no other masses are being missed. On ultrasound, again, it's a well circumscribed mass. Again, it's not as completely black or hypoechoic as a cyst would be. And again, here it is on a mammogram. Treatment options for a fibroadenoma. So most of the time it's just close observation. Fibroadenomas don't increase your risk of breast cancer. They don't turn into breast cancer, but they can do one of three things. They're going to grow, they're going to regress, or they're going to stay stable in size. So a great option is observation. So observation is the importance of monthly self-breast exams and then a formal ultrasound every 6 months for 2 years to demonstrate a stability. Now, why would we choose surgical incision? Well, if on follow-up imaging or exam, this mass is increasing in size, the size is more than 2.5 centimeters, the mass becomes painful, or if a biopsy is performed, there's any atypical cells on biopsy, that mass needs to be excised. So why is increasing in size or size important and needs to be removed? Although a fibroadenoma is not an increased risk for breast cancer, a growing fibroadenoma raises suspicion for a Phyllodes tumor. So here you have the progression for a fibroadenoma. A fibroepithelial lesion is kind of an in-between. On core biopsy, it's not definitely a fibroadenoma, but you can't on a core biopsy determine whether or not it's a Phyllodes tumor. So they call it a fibroepithelial lesion. Fibroepithelial lesions need to be excised. You don't need to excise a fibroepithelial lesion with wide margins, but it needs to come out so that pathology has the whole mass so they can determine whether it's a benign fibroadenoma or if they're going to actually call it a Phyllodes tumor. So what is a Phyllodes tumor? Well, Phyllodes tumor is actually a type of soft tissue sarcoma. The traditional term for that is a cystosarcoma Phyllodes. This usually occurs in women over the age of 40. Again, it's a round mobile mass. On exam, you really can't tell the difference between a fibroadenoma and a Phyllodes tumor, but it's usually larger. So a mass that's more than 4 centimeters in size, rapid growth. So fibroadenoma, or what appears to be a fibroadenoma in imaging that's growing in size, is suspicious for a Phyllodes tumor. There's no imaging that differentiates between a fibroadenoma and a Phyllodes. And there are 3 types of Phyllodes tumors, and they're based on mitoses per high power field. The 3 types of Phyllodes tumor are benign, borderline, or malignant, and those actually say how rapidly dividing is that Phyllodes tumor and what's the risk that it would recur locally within the breast. On pathology, it shows increased stromal cellularity, high mitotic activity, and as this pathology picture shows in the upper corner, leaf-like architecture. So leaf-like architecture is consistent with a Phyllodes tumor. So if you have a Phyllodes tumor, the recommendation is excision with grossly 1 centimeter wide margins. You don't need to do lymph node excision or biopsy. It's not necessary. Phyllodes tumors are actually similar to sarcomas, hematogenous spread. Traditionally, wide local excision and then close observation because most likely Phyllodes tumors tend to recur primarily in the breast again. So you're going to not need necessarily chemo or radiation as first-line treatment, but follow that patient closely. How about nipple discharge? So nipple discharge can be categorized one of 2 ways. So physiologic, totally benign, or pathologic, concerning for malignancy. Based on history and physical exam, it can give you a good differentiation of whether or not it's benign or malignant. So nipple discharge that's coming from bilateral breast, most likely benign. Um, Meaning that induced, meaning that it the patient expresses it on their own versus spontaneous, where it comes out on its own, where the patient says, I just noticed it on my bra, I noticed it on my pajamas. Spontaneous is more concerning versus if somebody's eliciting it on their self. If it comes out from multiple ducts compared to one duct, so multiple ducts might be fibrocystic, something more systemic compared to it's coming out by itself, one breast, one duct. Um, Physiologic would be thick. Colors that we associate with physiologic are green, yellow, brown, white. Malignant, concerning for pathologic would be bloody or clear. Let's go into color a little bit more. So color tells a lot of things. Green, yellow, brown is usually fibrocystic, ductictasia. White and bilateral is hormonal related. And blood is more concerning for an intraductal papilloma and secondarily cancer, whereas a clear, almost like water, is worrisome for cancer. Let's go over the workup for nipple discharge. So on exam, a patient comes in complaining of nipple discharge after you go through that history. Is it one side or both side, multiple ducts, what color is it, how does it come out when you do it yourself, or on its own? Then you're going to want to do it yourself. So you're going to try and elicit the discharge. And if you can't, you're going to ask the patient to do so. Again, you're going to look and see how many ducts is it coming out. And then you're going to palpate around the areola or the breast and see if you palpate, kind of the quadrants of a clock. If you palpate anywhere on the breast, does it elicit that discharge? Because that might tell you where that milk duct's or where that duct's coming from. If it's bilateral, you want to rule out a prolactinoma, so you're going to check TSH, prolactin levels. You're going to check current medications to see if there's any medications that might elicit nipple discharge, and then you're going to get your imaging. Mammogram, ultrasound that's directed retroareolar, MRI could be helpful, or a ductogram. And you would perform these in that order usually. So let's go over this. On an ultrasound, the radiologist may or may not be able to identify a mass within the duct, which would be most consistent with a papilloma. On an MRI, it's very sensitive, and so here you're able to pick out a mass that might not be seen with the ultrasound retroareolar because it's a little bit further out than the traditional retroareolar ultrasound. This is a ductogram, and so this is where the radiologist actually will cannulate the discharging duct. So this is a single duct, and they will inject radio contrast material, and then they'll look for where the arrow is pointing as what's called a filling defect to identify where there might be something in the milk duct blocking this and causing discharge. In the top right corner is actually a ductoscopy. So this is actually a scope. This is done in the operating room with a camera on it where the surgeon inserts the scope down the discharging milk duct to see if they can identify any pathology or mass within the milk duct. How do you manage nipple discharge? So despite the low likelihood of malignancy, it's recommended that all women with pathologic nipple discharge undergo a duct excision based on the inadequate sensitivity of the diagnostic modalities. So say you order a mammogram, ultrasound, MRI, ductogram, you're not able to identify anything. If somebody truly has single, unilateral, clear or bloody nipple discharge, they need surgery to rule out microscopic disease. Now, the number one cause of bloody nipple discharge, or the number one cause of discharge in general, is usually a papilloma. So a papilloma is a benign growth of ductal epithelium that creates an intraductal mass. It's the most common cause of bloody nipple discharge. Papillomas that are more centrally located are more likely to be solitary, benign, and cause discharge. More peripherally located papillomas are more likely to be multiple and be atypical or concerning for cancer. Papillary cancer itself is rarely rare, less than 2% of all breast cancers. To be safe, any papilloma that's identified on imaging and biopsy should be considered for surgical excision to rule out the chance of cancer or atypical cells, and especially any papilloma with atypical cells needs to be excised. So how do we do excision? So if there's two ways to do an excision. So if you have a papilloma, you're going to do a localized excision, whether it's a wire or seed placement, you're going to localize that papilloma to do an excision of that. If you're doing an excision for a nipple discharge where no imaging is able to identify a mass as a cause, you can do it in one of two ways. You can do a localized duct excision. So this is where when the patient's asleep, you're going to elicit nipple discharge, and then you're going to slide a lacrimal probe into that discharging duct. There's also where you can put an angiocath in and inject blue methylene blue dye to help identify that duct. So then what you're going to do is a perioral incision, identify that discharging duct, and then isolate that duct and remove that duct tissue. The other option is to perform a central duct excision. And again, this is where you're doing a periareolar incision. You're going to place your hemostat or tonsil clamp all the way around all of the milk duct tissue leading up to the nipple. You're going to tie that off, and then you're going to remove that tissue from directly at the base of the nipple all the way down approximately 1 to 2 centimeters around for a central duct excision. Again, any tissue that you remove, you're going to want to orient your specimen, especially where the duct is. How about a radial scar? So a radial scar is a lesion that measures less than 1 centimeters, whereas a complex sclerosing lesion is a lesion that measures more than 1 centimeter. It gives about a 2-fold increased risk of breast cancer. And the reason that a radial scar needs to be excised is that it does increase the risk of breast cancer, but on mammogram and ultrasound, it looks very similar to how a cancer would look. So when you get a biopsy of it, it can be a radial scar, but definitely radial scars and complex sclerosing lesions want to be excised because you want to make sure that it's not associated on the edge of a cancer, and it's very difficult to follow these in imaging because it looks so much like a cancer. So at excision, roughly about 20 to 22% chance of finding DCIS or an invasive lesion associated, so excision is recommended. This brings us into our high-risk lesions. So which lesions are benign, but they're high enough risk that they require surgical excision? So you want to remove these because they can have a chance of increased risk breast cancer of anywhere from 5 to 30%. So these are buzzwords. If you hear these need to be excised. There's no question. Atypical cells, atypia, something's abnormal, needs to come out. Radial scars, we just talked about, large fiber adenomas, as we talked about, Phyllodes tumors, papillomas, and I want to get into next atypical ductal hyperplasia, atypical lobular hyperplasia, LCIS, and as we talked about before, a discordant biopsy. High-risk lesions such as ADH, ALH, or LCIS increase risk of breast cancer over a woman's lifetime. These are high-risk lesions. These are the 3 main high-risk lesions. And it's easy to think about why they're high risk when we look at the development of breast cancer. So this is a simplified view. So everybody's breasts are made up of lobules and ducts. Lobules make the milk, ducts pump the milk to the nipple for breastfeeding. So 2 types of cancer you can get, lobular cancer and ductal cancer. Men don't make milk, so men don't have lobules. Men can only get ductal cancer. So if we look at this from a milk duct, so you cut one of these milk ducts in half. this is what the pathologist looks at under the microscope. So every um, month, just like our skin and our nail cells and regenerate, so do our milk ducts. So our milk ducts make new cells, old cells die. That's called usual hyperplasia because that's usually what happens. What we think happens for breast cancer is that for whatever reason, these cells that grow don't learn how are not dying. So they learn how to not die. And so what happens is these milk ducts fill with too many cells. And so that's called atypical hyperplasia, too many cells. And if it happens in the milk duct, it's called atypical ductal hyperplasia. If it happens in the lobule, it's called atypical lobular hyperplasia. What happens is that over time, for whatever reason, these cells continue to grow and divide, and they turn into cancer cells. Now, if you look at one of these cells under the microscope, it looks like a cancer cell. But the difference between a ductal carcinoma in situ or lobular carcinoma in situ and invasive cancer is whether or not these cancer cells have actually gone through the basement membrane of the milk duct. So if these cancer cells have maintained inside the milk duct or the lobule, they're called ductal carcinoma in situ or lobular carcinoma in situ versus invasive cancer. So keeping this spectrum of disease in mind kind of really helps us understand how and when to treat things. So let's take the lobules. So atypical lobular hyperplasia and lobular carcinoma in situ. These lesions represent a continuum and are collectively called lobular neoplasia. In general, neither ALH or LCIS is actually seen on a mammogram. They're typically an incidental finding on biopsy, and they're usually adjacent maybe to the target lesion on imaging. So these represent a discordant biopsy and need to be excised. They're not a diagnosis of cancer. ALH and LCIS are actually increased risk of breast cancer in either breast. They do need to be removed to make sure that they're not associated with any cancer in that area. But because the woman made atypical cells, she's at an increased risk for lifetime development of breast cancer. When we go to remove these are not a lumpectomy because it's not a cancer operation. So ALH and LCIS do not need margins because they're not a diagnosis of cancer. Lobular carcinoma in situ. So it's kind of a misnomer. It's not as concerning as ductal carcinoma in situ. LCIS is a high-risk lesion. LCIS gives a woman a lifetime risk of developing invasive breast cancer in either breast of 20 to 40%. Subsequent invasive cancer may or may not develop from the areas where the LCIS was found, and it can develop in either breast and be invasive ductal or invasive lobular cancer. Again, excision for LCIS is recommended. It's not a lumpectomy. You don't need margins. You just need to take out the area that was concerning on the mammogram or ultrasound. After excision to prove or not prove that a woman has associated cancer, if it's just the LCIS, these women should be offered high-risk screening. They could have an option for chemo prevention. And if they have a strong family history, they actually can consider bilateral prophylactic risk-reducing mastectomies. Now, pleomorphic LCIS is a term that is kind of in between LCIS and DCIS. So it's called cancerization of the lobules by DCIS. And it's a term that pathology will put on their report. And it's a very high risk for having an associated cancer, most likely DCIS. So with pleomorphic LCIS on a core needle biopsy, there's about a 50% chance of finding an associated cancer on excision, and it's usually finding associated DCIS. So when you have the diagnosis on core biopsy of pleomorphic LCIS, you do want to do a lumpectomy. You want to do an excision with negative margins so that if it is an upgrade to cancer, you've got clear margins. And if it is just pleomorphic LCIS, then excision with clear margins is good. Atypical ductal hyperplasia. So it is the most common benign high-risk lesion of the breast. About 20% of all biopsies for calcifications will come back atypical ductal hyperplasia. Again, as we talked about, atypical ductal hyperplasia is abnormal proliferation of the normal ductal cells. And again, it's a spectrum between usual hyperplasia and DCIS. It indicates an increased risk of breast cancer, about 4 to 5% increased, or 4 to 5 times increased risk. For a diagnosis of ADH, excision is recommended to rule out cancer. Number one, to remove that area, and it's about a 30% risk of associated cancer or DCIS on excision. If a patient has a high-risk lesion that's removed, the next question is how to manage these patients, how to follow these patients. So for whatever reason, that patient made atypical cells that increase their lifetime risk of getting breast cancer. How risky is that? There are a lot of different calculators that are out there, and I chose for this talk to focus on two different ones, the Gale model and the Tyrer-Cuzick model. So both of these are used. Gale model looks at hormone exposure and how many biopsies and family history, whereas the Tyrer-Cuzick looks at those as well and really dives into somebody who's got a strong family history but doesn't carry a gene. So both of these give a calculated estimate lifetime risk of developing breast cancer. So a woman is considered high risk if her 5-year risk is greater than 1.7% or her lifetime risk is greater than 20%. What about BRCA testing? So BRCA, BRCA are genes that increase a woman's risk of breast cancer. And as we know more and more about genes, we add more and more genes to these panels. So you always want to test the person who has breast cancer. So if a woman comes to you for high-risk screening and her mom had breast cancer with a strong family history, you're going to want to test that mom. So the indications are continually expanding, but a good place to start is for a woman who has breast cancer or DCIS under the age of 50, anybody with bilateral breast cancer, Ashkenazi Jewish ancestry, a triple negative breast cancer under the age of 60, 2 or more first-degree relatives for breast cancer. So that's mother, sister, daughter with breast cancer, a family history of ovarian cancer at any age, any history of male breast cancer, or metastatic prostate cancer. These women are at the highest risk of testing positive for the BRCA gene. And now, out of all these women that might meet this criteria, the risk of actually carrying that gene is maybe about 10%. Let's specifically look at the BRCA1 and 2 genetic mutations. So this is a mutation in either BRCA1 or 2. Tumor suppressor genes. A mutation in one of these genes can cause breast cancer. Again, only about 5 to 10% of all breast cancers. The BRCA1 gene is located on chromosome 17, and the BRCA2 gene is located on chromosome 13 and is associated with male breast cancer. BRCA genes is autosomal dominant inheritance, either sex, and a 50-50 chance of getting it. BRCA1 gene lifetime risk of breast cancer is 60 to 80%. Lifetime risk of ovarian cancer is 20 to 40%. It's usually associated with triple negative breast cancer and occurs in our younger women. BRCA2 lifetime risk of breast cancer is 45 to 65%. Lifetime risk of ovarian cancer is 15 to 25%. Males can happen about 6 to 8%, and it's associated with other cancers. So good screening for patients that have different family cancers, so colon, pancreatic, and prostate. What are options if patients are BRCA positive? Well, they could have bilateral prophylactic risk-reducing mastectomies. Decreases the risk of developing breast cancer, nothing in life's 100%, but down to about 3 to 5%. Patients can elect to undergo high-risk screening. So again, that's annual mammogram, annual MRI, alternating every 6 months. That goes along with a clinical breast exam every 6 months. They could do tamoxifen for risk reduction or prevention. For the ovarian risk for BRCA genes, they could consider bilateral salpingo oophorectomy by the age of 40 or after childbearing. Ovarian cancer screening consists of transvaginal ultrasound and a CA-125 every 6 months. These are different genes that increase a woman's risk of breast cancer. So you have your BRCA1 and 2, which are the highest risk. Your P10 is a high risk of breast cancer. Your P53, STK11, which is your Peutz-Jeghers, your CDH1, diffuse hereditary breast cancer, and PALB2. It's difficult to remember all of the genes that are associated with breast cancer, so I put this table on for reference. This is hereditary lifetime risk of breast cancer. Again, these genes are up here and the risk of different breast cancers during the lifetime. This will conclude our talk on benign breast disease.